Alright, now on to another high-yield topic. Pleural effusions are classified as transidative or exudative depending on the underlying process causing them. Transudates have a low protein content, or a fluid to serum protein ratio of less than 0.5, and a fluid to serum LDH ratio of less than 0.6 when you are looking at the pleural fluid. How do transudative pleural effusions occur? They happen when either the transcapillary pressure gradient is increased or the serum protein content and thus the oncotic pressure is decreased, such as in congestive heart failure, nephrotic syndrome, or hepatic cirrhosis. You can go back to the capillary fluid exchange fact on page 291 for a quick review of these startling forces. Exudates, on the other hand, have a higher protein content, with a fluid to serum protein ratio of greater than 0.5 and a fluid to serum LDH ratio of greater than 0.6. Now, what drives exudative pulmonary effusions? They occur as a result of processes that affect capillary permeability, such as malignancy, pneumonia, and collagen vascular disease. Exudative effusions typically need to be drained due to their increased risk of infection and empyema formation. One other type of exudative effusion worth mentioning is a lymphatic effusion, or chylothorax. This is typically seen when the thoracic duct is damaged during cardiothoracic surgery or blocked by a malignancy. When you tap the effusion, you typically get a milky white fluid. So why is it white? Well, because it's full of triglycerides.
Finally, we get to pneumothorax, which is also new for 2012. Now, that being said, we discussed earlier on page 571 how pneumothorax can present with the classic absent breath sounds, hyperresonance, and decreased fremitus. Patients may also have some chest pain and shortness of breath. Primary spontaneous pneumothorax typically occurs in tall, thin young males who have these apical blebs that pop, but who are otherwise pretty healthy. So why does this happen? Well, no one is sure, but it's thought to be related to increased shear forces in the apex during respiration. There are some cases of familial pneumothorax. So you might see pneumothorax with Marfan syndrome, Ehlers-Danlos syndrome, and homocystinuria. You can also have secondary spontaneous pneumothorax, which can occur with a variety of lung diseases. So what would be the most likely lung condition to do this? Well, COPD with emphysema accounts for about 70% of these cases. Other lung conditions to keep in mind include severe asthma, cystic fibrosis, pneumonia, interstitial lung disease, connective tissue disease in the lung, and lung cancer. Patients here have more severe symptoms and possibly hypoxia because their other lung can compensate. Other types include traumatic and iatrogenic pneumothorax. You can probably guess what's going on here. The causes include any trauma or injury to the chest, like from a car accident or a knife wound. Of course, you as the doctor or future doctor could also be responsible for this by doing what? What could happen when you try to place a central line, biopsy the lung, or put the patient on mechanical ventilation, or really any type of positive pressure ventilation? As we mentioned earlier, tension pneumothorax is one of those few respiratory emergencies where you may have to take definitive action before the person even gets to the emergency room. This usually starts as a traumatic or iatrogenic pneumothorax where the air enters the pleural cavity but can't exit because of a one-way valve mechanism. When too much air gets trapped, it pushes the mediastinal structures to one side, as you can see here. These patients can be in severe respiratory distress that evolved into hypoxia, hypotension, and cardiovascular collapse, in addition to the other classic symptoms that we talked about. If the patient's in severe distress or looks unstable, what would you do next? Well, you have to do a needle decompression immediately, even before you can confirm the diagnosis. So they ask you on the boards, reach for the needle first, then get the chest x-ray later.